Now we will review the diseases of the nasopharynx. The most common infection in the nasopharynx is the infection of the nasopharyngeal tonsils, which is the adenoids. What is adenoids? Adenoids is the infected or enlarged nasopharyngeal tonsil. Nasopharyngeal tonsil, it's a site at the angle between the prevertebral muscles related to the first cervical vertebrae and the base of the skull. The nasopharyngeal tonsil is one of the protective mechanism of the pharynx, the inner ring of protecting mechanism of the aerodigestive tract, which includes the lingual tonsil, the palatine tonsil, the nasopharyngeal tonsil, and the tubal tonsil. The nasopharyngeal tonsil increase in size physiologically gradually until it reaches its biggest size at 6 years of life, and then gradually decrease in size to disappear at about the 12 years of life. The nasopharyngeal tonsils become infected to cause adenoiditis, or increase in size to cause adenoid hypertrophy. So we can say adenoids if infected or if increase in size. But what is the causes which lead to adenoiditis or adenoid atrophy? First, number one, this is generalized lymphadenopathy. This may be physiologic hyperplasia of the whole lymphoid system. This may be physiological or may be response to viral infection. Then rhinitis. Any recurrent attacks of acute rhinitis can infect the nasopharyngeal tonsil and cause adenoiditis. Also, recurrent attacks of sinusitis can infect the adenoids. Also, tonsillitis. Recurrent attacks of tonsillitis can cause adenoiditis. Also, allergic rhinitis usually increase the size of the nasopharyngeal tonsils. Finally, malnutrition. Malnutrition usually predisposed to all infections, all types of infections, and it is a very important factor in causing adenoiditis. Now, what is the clinical picture? The clinical picture in this table is summarized that symptoms due to hypertrophy, symptoms due to infection, general symptoms, and reflex symptoms. First, we have adenoid hypertrophy symptoms, symptoms due to enlarged size of the adenoid. First here, the nose. What the adenoid hypertrophy will cause to the nose? First, nasal obstruction. Second, difficult feeding or suckling, especially in infants. Then snoring due to partial nasal and airway obstruction. Then the nasal tone. This is a type of rhinolalia clausa. And also obstructive sleep apnea. What is the adenoid hypertrophy cause to the ear? This usually causes ostical obstruction and otitis media with effusion. What will do to the chest? We can see here the Harrison sulcus. Here, retraction of the lower part of the sternum, and finally the pigeon cyst. All this are due to the respiration under resistance. The patient try to take respiration from the nose under high resistance, and this will cause these chest manifestations. Finally, what will cause adenoid hypertrophy to the face? This will give me the adenoid face. What is the adenoid face? This usually open mouth, thick lip, absence of the nasolabial fold. This usually due to the disuse of the orbicularis muscle. Here, the slit-like nasal opening is usually due to atrophy of the ala nasi. Then high arched palate due to loss of molding and adaptation of the tongue on the palate during its growth. Then overcrowded and prominent incisor teeth. Finally, the receding chin or receding lower jaw due to loss of the negative intrabuccal pressure. Now, what about the symptoms due to adenoid infection? First, to the nose, rhinitis and sinusitis. To the ear, acute subarachnoid otitis media and chronic subarachnoid otitis media. To the chest, bronchitis and cor pulmonale. What about the general symptoms? The patients usually complain of delayed speech, of course, because there is otitis media with effusion, conductive deafness, hypoxia during sleep, so delayed speech. Also growth retardation. This is the scale, and this child is under growth. Also lack of concentration. There is hypoxia during sleep, there is mouth breathing, there is conductive deafness, so there is usually lack of concentration. What about the reflex symptoms? Nervous system, anorexia, and convulsions. The respiratory system, chronic cough and asthma. About the digestive system, usually morning vomiting and indigestion. Investigations of patient with adenoids. Plain X-ray lateral view of the nasopharynx. We can see here that this is the base of the skull and this is the first cervical vertebra. At this angle, this is the adenoid. And we can see soft tissue mass here closing or obstructing the air column. This is the air column and obstructed here, and this is a big adenoid. Here, nasopharyngoscope by the flexible nasopharyngoscopy. This is the choana, and we can see here the adenoid obstructing the posterior choana. What about the treatment? Sometimes there is mild cases and patients or children below 1 year of life. These patients, we can give medical treatment in the form of antibiotics to treat infection. We can do anti-inflammatory to decrease the size of the adenoid, and we give balanced diet to prevent malnutrition and to increase the immunity. But the main treatment of this adenoids is surgery, adenoidectomy. What is adenoidectomy? Adenoidectomy is to remove the adenoids if enlarged or infected to cause symptoms. This can be done as early as 1 year of life. Any child at 1 year, we can remove the adenoid. What is the contraindication? Generally, any bleeding disorders like hemophilia or purpura and so on, any problem which cause the patient cannot use anesthesia, or like cardiac problems and chest problems, and cleft palate. Why cleft palate? Contraindication to remove adenoids because the the palate is very important part in the nasopharyngeal sphincter, which prevent food and fluid regurgitation during swallowing. And this very important if we remove the adenoids, which play part in closing the velopharyngeal sphincter in patients with cleft palate. This will cause velopharyngeal incompetence, and you will see nasal tone very difficult to treat, and sometimes regurg of food and fluid from the nose. Now, what about the complications of adenoidectomy? This is the head of the patient. This is the mouth opened by the mouth gag here. This is the palate. This is the head, and this is the pharynx. This is the larynx and the trachea. We usually use the adenoid curette here and to shave the mass of the adenoid through the mouth, so you can cause the following complications. First, epistaxis or bleeding or hemorrhage. Epistaxis because blood comes from the nose, hemorrhage because blood comes from the mouth. This may be reactionary, means within 24 hours of surgery. This most probably due to incomplete removal, but sometimes due to excessive removal also can cause reactionary hemorrhage during the 24 hours of surgery. Secondary hemorrhage is usually due to infection from 3 days to 10 days, and both of them are treated by putting a post-nasal bag in the reactionary hemorrhage. This may be 24 to 48 hours. In the secondary, better to leave the bag at least for 5 days. Then injury. This curette can cause injury to the palate. This will cause nasal tone or sometimes regurgitation from the nose. Second tube injury, this will cause conductive deafness due to otitis media with effusion. This injury to the prevertebral muscles, and this may cause torticollis. Then inhalation of blood. Why during operation you can inhalate blood here? Because there is no cuff in the endotracheal tube. The endotracheal tube should have cuff to prevent inhalation of blood or the adenoid tissue to the chest. If this not happen, the patient may complain of lung abscess or lung collapse. Then the last complications is recurrence, and this usually due to incomplete removal. Now, what about the nasopharyngeal angiofibroma? The nasopharyngeal angiofibroma is the most common benign tumor of the nasopharynx. It is a benign tumor, but with aggressive behavior. It is most probably hormonal due to estrogen-androgen imbalance. Why? Because there are some important factors. This is mainly a tumor of male, usually the age between 10 to 12 years. The mass usually regress at the age of 25 years. But there is some theories that this tumor may be hamartoma or part of a paraganglioma. What is the origin of this tumor? It arises from the region around the sphenopalatine foramen. What is the sphenopalatine foramen? It is a foramen connect laterally the nasopharynx to the sphenopalatine fossa. How we can find it? It is about 1 centimeter posterior and slight inferior to the middle turbinate. This is the sphenopalatine foramen in the CT. What is the main blood supply of nasopharyngeal angiofibroma? This is the maxillary artery. The maxillary artery branches the sphenopalatine artery here at the region of the sphenopalatine foramen, and the maxillary artery is a branch of the external carotid artery. Now, what is the histopathology? There are two types of blood vessels in a stroma of fibrous tissue. This fibrous tissue with blood vessels and muscle cord. And this is fibrous tissue with blood vessels which deficient or with no muscle cord as we see here. And this is the type of bleeding. If the fibrous tissue is too much, this is called fibroangioma and with little bleeding. If the blood vessel too much, we can say angiofibroma and with severe bleeding. And because this is a male tumor, we can say this juvenile angiofibroma. Now, what is the clinical picture? The early symptoms and the signs are nasal obstruction. Usually, this is due to a small tumor in the region of the sphenopalatine region, as we see here. At this tumor, we can just say nasal obstruction, epistaxis, recurrent attacks of severe epistaxis, and this depends on the types of the blood vessels. If the blood vessels have many vessels with no muscle coats, will be severe epistaxis. Also, there is a nasal tones which is called rhinolalia clausa. So the early symptoms are obstruction, epistaxis, and nasal tone. Then there are signs of extension and increase the size of this tumor. If extended to the nose, we will have broadening of the nasal bridge. If extended to the nose sinuses, especially the ethmoid, and to the orbit, this will cause the proptosis and what's called frog face deformity. If extended to the cheek, as this case here, you will see swelling of the cheek or called facial swelling. Also, this can extend to the middle cranial fossa, causing intracranial complications, and can extend to a Eustachian tube, causing otitis media with fusion. Now, what is the investigations? CT, to know the size and origin of the tumor and its extent. MRI, very important here, to see if there's any intracranial complications. Nasal endoscopy, to see the mass here and take care during the endoscopy not to make bleeding, to see the mass. And selective arteriography is very important here to define the main feeding vessel, which usually is the maxillary, and to know the vascularity of this tumor, and here it's very vascular. Finally, we have to say no biopsy, no biopsy, no biopsy, because this is contraindicated, because this may cause severe bleeding. Now, what is the treatment of nasopharyngeal angiofibroma? Mainly surgery, mainly surgery, mainly surgery, and we usually use embolization. We make selective arteriography and they make embolization, embolus surgical or intervention or injection of artificial embolus to close the feeding vessels here. And we see here how much the vascularity changed before embolization and after embolization, and this will decrease the bleeding during operation. The first modality of treatment now is the endoscopic approach, removal by the endoscopic approach. Now we can also use the lateral rhinotomy approach. This way, the incision between the nasal bridge and the inner canthus at the nasopharyngeal fold to the columella, open, remove the mass, and then close by plastic sutures. This is a transpalatal approach. This is the incision to remove the palatal flap, to reach the postnasal space, to remove the mass, and then close, put back for 1 week, and then close the palatal flap. Only for some inoperable cases or recurrent cases for an old patient not fit for surgery, or any patient which we cannot do operation for him, we can use radiotherapy, but this not recommended. Also, some use hormonal therapy to reduce vascularity, and for us also not recommended. What is the most common tumor of malignant tumor of the nasopharynx? This is the nasopharyngeal carcinoma. When we say nasopharyngeal carcinoma, you have to put on your mind some very important points. First, fossa of frozen molar. What is fossa of frozen molar? Some collections of lymphoid tissue just above and behind the pharyngeal opening of the Eustachian tube, because this is the main site of origin of the nasopharyngeal carcinoma. Second, you have to remember Epstein-Barr virus, which is related to some types of malignant tumors, especially the nasopharyngeal carcinoma. We found that these people of nasopharyngeal carcinoma usually have high titers of Epstein-Barr virus. And after this, you have to know also very important things. The most early signs of nasopharyngeal carcinoma is lump in the neck or enlarged lymph node and otitis media with effusion. You have here to start investigations and treatment as early as possible, because if you use radiotherapy here, you can save the life of the patient. If you take much time to make the clinical picture, which we will review later, this will endanger the life of the patient. So please, if you find lump in the neck and otitis media, this is nasopharyngeal carcinoma until proved otherwise, and you have directly make investigations in the form of CT to find the mass, in the form of nasal endoscopy to see the mass, and take biopsy to find the histology of the nasopharyngeal carcinoma. Investigations here should be CT, nasal endoscopy, biopsy, and also the titer of the Epstein-Barr virus. Now, what about the clinical picture of nasopharyngeal carcinoma? As I said before, the first degree very early is the lump in the neck, enlarged cervical lymph nodes, and otitis media with effusion due to compression or invasion of the Eustachian tube. Second, directly, the nasal obstruction and epistaxis. Epistaxis is not severe like in the nasopharyngeal angiofibroma. After this, the third stage here is late signs. This will affection of the third, fourth, and sixth cranial nerves. This will called paralysis and called ophthalmoplegia. Then fifth nerve paralysis. This will cause trigeminal neuralgia. Then 11 nerve paralysis, this will cause palatal paralysis. And palatal paralysis is the early sign, usually early sign, due to affection of the 11th cranial nerve. The paralysis of the palate here will be diagnosed as regurgitation of fluid and food from the nose, and also deviation of the uvula to the normal side. Then affection of the hypoglossal nerve, this will cause tongue paralysis, and affection of the 10th cranial nerve, which cause vocal cord paralysis. Now, what about the Trotter's triad? It is a triad to diagnose the nasopharyngeal carcinoma. If you have patient with this 3 triad, this symptoms and the signs is a nasopharyngeal carcinoma. First, affection of the trigeminal nerve we cause facial neuralgia, trigeminal neuralgia. Then, local invasion of the Eustachian tube will cause conductive deafness due to otitis media with effusion. Also, there is homolateral palatal paralysis, as I said, nasal regurgitation and deviation of the uvula to the normal side. Take care, this Trotter's triad is due to local invasion of the tumor to the 5th cranial nerve, the Eustachian tube, and to the soft palate. Thank you.